This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 16, Envenomation. Key concepts. Upon completion of this chapter, you'll understand envenomation from Hymenoptera Stings, and this would be like rattlesnakes, cottonmouths, copperheads. The Hymenoptera would be things like bees and ants, arachnoids, spiders, scorpions, Cnidaria, mollusca, and spiny fish. Stingray lionfish on the spiny fish. Mollusca would be cone snail octopus, and Cnidaria would be jellyfish, corals, and sea anemones. Assessment and treatment of envenomation. So, quick overview. Envenom patients. Management can be challenging. Some common situations which we see are like bee stings, and some rare situations like rattlesnake bites. And familiarity with the situation, it helps the evaluation and the treatment of the patient. Chief concerns: Hymenoptera stings. Most envenomation deaths in the U.S. occur from this. Most stings go unreported. Death generally is due to an allergic reaction. Range of reactions from pain and swelling to rapid airway loss from anaphylaxis. And this would be from a systemic release of histamine. Hymenoptera stings include Aspis species, or bees, and Vespid species, which are like wasps, yellow jackets, hornets. Most anaphylactic reactions occur from these species. Formicide also, which is ants, and ants tend to get aggressive whenever you threaten their colony, their nest or their hive, and this is all of them. So if you are threatening a hornet's nest or you are threatening the queen bee, you're probably going to get stung. Physiology: venom is full of proteins and peptides, and direct toxicity, and this activates the immune system, and an allergic reaction develops. That's what we worry about the most from these stings. Snakebite. Data is limited. Mortality in the United States is pretty low. Venomous snakes in the U.S. approximately 30 species. Vipera day. Most common envenomations, and this includes things like rattlesnakes, cottonmouths, and copperheads. And a Lapidae group, which includes coral snakes. Venomous versus non-venomous snakes. Venomous snakes bite with the fangs, and non-venomous snakes have teeth, but they don't actually have fangs. The venomous snakes, single row of scales on their belly to help identify. Always be safe. Be sure, if you are going to bring the snake at all, that it is absolutely dead. You do not want to get caught in the back of a transporting ambulance with something that might still be able to bite you and be poisonous. Snakebite continued. Pathophysiology: venom mixture of proteins, peptides, lipids, carbohydrates, and enzymes. Many components remain unidentified in snakebite venom. Very stable and is not sensitive to heat. Anaphylaxis from the venom generally is what we worry about the most in this. Reactions similar to anaphylaxis from any cause. Rapid onset of airway edema, rash, and hypotension. Pit vipers. Heat-sensing pit located between their eyes and their nostril on either side of their head. Known for their fangs, rattlesnakes have the longest version of these fangs. Lapids, or coral snakes, they're found in the southern temperate areas of the United States. And they're identified by a red, yellow, and black banding that runs along their body. Some people use a rhyme: red on yellow will kill a fellow, and red on black, friend of Jack, or venom lack. Spiders. Carnivorous arthropods. Most encounters are benign. Some need pre-hospital intervention. Black widow being one of these. There are several different types of black widows. There's the black widow proper, western black widow, northern black widow, brown widow of the south, and the brown button spider or brown widow. Pathophysiology of this, very, very potent venom. Primary agents are responsible for most of the clinical effects is alpha-itrotoxin, which is a neurotoxin that causes a release of neurotransmitters from presynaptic nerve endings, and more specifically calcium. Brown recluse spider, pathophysiology on this, a small amount of toxic venom, has many components. Hyaluronidase is one of the components, helps the venom actually move through the tissues, and sphygmomyelinase, a venom component responsible for the breakdown of tissue from cell death. Now, brown recluse spider bites are known for their tissue destruction locally, but it's the venom that actually does that. Scorpions, arthropods as well. They envenom by stinging through a specialized apparatus called a telson, and this is a telson, which is their stinging apparatus. 1,000 species of scorpions, 20 of them are medically important. Pathophysiology, venom, a complex mixture of toxin, primarily neurotoxic as well. The toxins are active on the voltage-gated ion channels at the neuromuscular junction, and they primarily affect the sodium channels, cause repetitive firing from sympathetic and parasympathetic nerves, allowing for the release of acetylcholine and catecholamines. That's what this venom causes. Marine envenomation, not an uncommon occurrence. In many cases go unreported, though. You would think this would be pronounced Cnidaria, but it's actually a silent C. Cnidaria, which includes jellyfish, corals, and etc. Pathophysiology on this is a nematocyst, my apologies. And the nematocyst is their stinging apparatus. And what I got over here, this is their actual surface of their skin. And upon contact, thousands of these little needle-like projections with the toxin in it shoot out from their skin in all directions. And the fish or the person that gets touched by these things get that envenomation through all of these little devices. Other marine envenomation we can see is mollusca, cone snails, and octopus, and then spiny fish and stingrays. Envenomation from spiny fish and stingrays are not common in the United States, and fatalities are very uncommon. History. Scene safe, utmost importance here. Not safe for capture. Do not try to capture these animals unless they're already done so, and then be sure that they're not alive if you're planning on taking them from point A to point B or to the hospital for identification. But the identification, if you can come up with it, can be helpful. Directed patient history, stratified those at high risk, and then differentiate different envenomation types. So off of a history of presence and their symptoms is how we're probably going to be able to identify these. History of present illness. Get as much information as possible. The standard OPQRST mnemonic is helpful to evaluate this. Examples, and here would be some history questions. So when did the envenomation occur? So you got a time clock. Where did this happen? Was there prolonged evacuation? Did anyone see the offender, spider, snake, scorpion, etc.? Did you have any symptoms initially? Have you ever been envenomated or stung before? Have you ever received antivenom in the past? If so, how long ago and what type? And was there any care or treatment prior to the hospital arrival? And there's all kinds, you got to be aware of this one, there's all kinds of wives' tales out there that people may try to home remedies, so to speak, that you can essentially, that are not helpful. One of the examples that I heard one time was using a stun gun to stun the snakebite venom. Probably just causing more pain here. If anything, we want to try to decrease the patient's anxiety and not increase it and bring the venom throughout the body. Tad of common sense. Medical history. Important to better risk stratify the patients as well. Patients at risk for worsening clinical symptoms, and this would be patients like that have pre-existing conditions or comorbid factors that would make them sicker. They already had a cardiac history. They already had a history of COPD, and all of a sudden they're going in anaphylaxis. Things are not going to come out well, so we got to really get aggressive and get ahead of this. Any kind of allergies or any kind of risk for anaphylaxis. Food allergies, medications, environmental allergies, the more risk factors that you actually have, the worse off that you can be. History prior to envenomation, and any kind of anti-venom use and tolerability. If they've had it before, were they tolerable to it, or did they tolerate it well? Examination, initial evaluation, ABCs that are rarely affected by the venom unless it is something that is not known to the continental United States. Airway obstruction edema may occur, but this is from an anaphylactic type response. May require aggressive airway intervention, including intubation and surgical airway. Frequently assess their vital signs and look at the patient for hypotension and tachycardia. These will give you your first symptoms of loss of containment. Carefully examine the affected area and reassess throughout the treatment and transport. ABCs continuously and any kind of interventions done on this patient. Examination of Hymenoptera, broken down by the type of reaction. So if it's a local reaction, which are most common, swelling, pain, redness, erythema, and pruritus or itching, larger areas, nausea and weakness can occur. If we go full anaphylaxis or it's systemic, we get a systemic allergic reaction. These can occur very quickly with one sting. Now, most people think that you have to be stung twice. The only thing that getting stung twice does is it prepares your immune system. The person was allergic to it the first time, but the second time that they got introduced to it, it's going to be worse than their first reaction. Now, a person can be allergic to this and have an anaphylactic response first sting. Medical emergency, dramatic presentation, diffuse urticaria, erythroderma, widespread redness areas all over the skin, and angioedema. The angioedema is what we worry about. The swelling of the tongue, the swelling of the upper airway, we may have to get very, very aggressive on airway management. Snake identification. Do not attempt to capture or transport the snake, even if thought to be dead. We do not want to get ourselves into a situation to where we have an animal that is now loose in the back of our ambulance while we are trying to go down the road. Bite patients, often unable to identify the snake. It happened very, very rapidly. Snake identification, often impossible. It's helpful to know what snakes are indigenous to the U.S. or if there was any witnesses of what type of snake that they thought it was. Examination of the snakebite. Important elements, fang marks or characteristics. The features of the snakebite and the areas in between them. Measurement of those areas gives us an assessment of how big the snake was. Severity and clinical effects are variable, and this would be based on the patient's age, if there's any comorbid factors, the sensitivity of the patient to the venom, the amount of venom effects, and the time since envenomation. Systemic symptoms, nausea, vomiting, numbness, tingling, diarrhea, and a metallic taste in their mouth. Airway compromise is uncommon, but may occur as a result of the primary venom effect on the immune system or have an anaphylactic response. Examination of a black widow spider bite. Most of the time, whenever we see a black widow spider bite, the shape is often disassociated or not thought of as very much, thought of it as a pinprick, and this is a black widow spider bite here shown. Very, very subtle. Systemic symptoms can start within about 30 to 60 minutes or can be delayed for a few hours. They generally start at the site and spread outward, but they are muscle pain and cramping, and then this starts progressing to larger and larger muscle groups. Facial swelling can occur. Latrodectus facies is one of the things. This doesn't occur that often, but it can occur. Drooping of the eyelids, runny nose, conjunctivitis, and facial spasms. Nausea, vomiting, and tachycardia are all systemic symptoms of a black widow spider bite. Remember, it releases the calcium, will cause erratic firing. neurotoxic. Examination, brown recluse bite. Important elements on this, and I'll clear this off of here. Generally painless, may go unnoticed for 6 to 12 hours in general. Lesion is a necrotic arachnidism formation and blistering. Initially, we'll get a papule formation on this site, and then it tends to blister from a bulla. Reddish bulla surrounds by a bluish area, and generally will have like a narrow white blanched area between the red and blue. They refer to this as kind of a bullseye pattern, and it may be a little difficult to see, but let's see if I can change colors of this little white blanched area here, and I'll clear this off so that now that I've made notice of it, you can see it. And then we have a blue area here, and then this whole area is reddened. So they refer to that pattern as a red, white, and blue pattern sometimes. But this is what a brown recluse spider bite may look like 6 to 12 hours after the injection of the poison. Systemic response is rare, but if they're going to occur, they usually occur in 24 to 48 hours after the bite. Examination of a scorpion bite. U.S. scorpion stings generally don't cause local tissue destruction. They produce pain at the site, localized paresthesis, numbness, tingling, begins soon after the envenomation and often resolves within a couple hours or hours to days. More significant envenomation occur or is more likely to occur in infants and small children, and it may cause tachycardia and hypertension. Examination of a Cnidaria sting or jellyfish most commonly causes pain almost immediately after introduction to this. Pain can be significant. Systemic toxicity is kind of uncommon on this. We get a urticaric-like rash that may develop, and that's what we're seeing over here. Sting includes Cryonex fleckeri, jellyfish, and the Portuguese man-of-war, and the fire coral. Fire coral tends to cause burning type of pain when touched. The Portuguese man-of-war, primary clinical effect is pain, can also cause generalized weakness, limb numbness and tingling, nasal and ocular discharge, muscle spasm, and in severe cases, renal failure and death. Assessment. Cordyline bites. Most are subcutaneous, occur on extremities, can be intramuscular or intravascular, result in rapid venom effect if this occurs. Difficult to distinguish from an allergic reaction. Most envenomations create localized trauma and are self-limiting. Treatment. Focus on symptomatic care. Safe transport to the appropriate facility. Initial treatment should be focusing on the airway, breathing, and circulation and apparent allergic reaction. Treat similarly to anaphylaxis. Keep in the back of your mind and keep on standby the ability to intubate, any type of surgical airway that might be applied, or medications that might be required. Special considerations. Treatment of snake bites. Intravenous access is important. Tourniquets should be avoided. Bite to the extremity should be immobilized. Narcotic pain medications may also be helpful. Treatment of arthropods and stings. No specific pre-hospital treatment for arthropod envenomation exists. General symptomatic and supportive. If they have pain, correct the pain, watch for anaphylaxis, general supportive care, and get them to the hospital. Treatment of Hymenoptera stings. Treat aggressively any kind of allergic reaction. Remove the stinger. Don't squeeze it, kind of scrape it off. Local findings, diphenhydramine and ice packs, allergic reaction or systemic non-allergic reactions, intravenous access, and then treat them like they're having anaphylaxis. Treatment of marine envenomation, directed at preventing further firing of the nematocysts, and that would be those little hair-like projections. Vinegar or acetic acid tends to work with this, about 4 to 6%. And is commonly the accepted treatment. Tentacle removal should occur. Wounds caused by stingray, coral, or lionfish may require immediate wound care and antibiotic therapy later. Use of antivenom in general. Product used to halt the progression or reverse the signs and symptoms after envenomation. Made by inoculating animals like horses and sheep with the venom of the target species. Animal is often allowed to create the antibodies of the venom. Crotalidae polyvalent antivenom is the most common version of this in the United States. Evaluation. Potentially envenomed patient, vigilant monitoring and reassessing of their vital signs and physical findings at the site. The airway should be continuously assessed and reassessed, especially with any kind of allergic reaction concerns. As far as disposition goes, suspected envenomation and transport them to the closest appropriate facility. Symptoms may not be immediate. Encourage the hospital's evaluation. Considerations on this should be the patient status and if the antivenom is actually available at that hospital. In conclusion, stings and bites. Most are benign. They invoke a big emotional response, especially if you just got bit by a black widow or a rattlesnake. Paramedic must evaluate the patient, determine the level of the emergency, and treat the patient accordingly. References for this are taken from Professional Paramedic Volume 3, Trauma Care and EMS Operations of Delmar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.